sinus retroperfusion. It's an approach to the treatment of myocardial ischemia that has fascinated cardiologists for years. And today, there's a great resurgence of interest in the coronary venous system as an access route for retroperfusion. We'll see why on today's Cardiology Update, produced in cooperation with the American College of Cardiology. And now, here's our host, Dr. Jeremy Swan.
40 years ago, the principle of retroperfusion of the myocardium via the coronary sinus failed. Today, modifications have allowed for the practical application of this principle. We show now a dramatic example of this application in a case described by Dr. Neil Eigler.
Our patient is a 63-year-old man with the recent onset of progressive angina documented on exercise stress testing, who underwent coronary angiography, which showed a 90% stenosis of the proximal left anterior descending and good left ventricular function. Because of the diagnosis of unstable angina and high-risk coronary anatomy, he underwent PTCA with retroperfusion. The PTCA was uneventful. However, 5 minutes after completion, the patient developed severe chest pain and developed rapid cardiogenic shock. This was unresponsive to conventional therapy, and retroperfusion was reinstituted at that time. Retroperfusion was continued for a total of 2.5 hours until the patient underwent uneventful coronary artery bypass surgery. These are side-by-side two-dimensional echocardiograms taken during cardiogenic shock with closure of the left anterior descending with a wide QRS rhythm, and following the institution of retroperfusion with restoration of normal sinus rhythm. These are both in the apical four-chamber projection with the septum, apex, lateral wall of the left ventricle in this orientation. During shock, there is severe akinesis of the septum and apex, as well as hypokinesis of the lateral wall. During retroperfusion, the septum and apex are now moving normally.
For more than a decade, Dr. Elliot Corday and his colleagues have worked to avoid prior failures, developing synchronized diastolic retroperfusion with blood and retroinfusion with drugs. After the break, we'll visit Dr. Elliot Corday in his laboratory. Stay with us.
To Dr. Elliot Corday's laboratory at Cedars-Sinai Medical Center, where he talked about the physiologic rationale for coronary sinus retroperfusion.
We see that following coronary occlusion, when we pump the blood in through the coronary sinus, it will cross over into the arteries, and that's because of differential heads of pressure in the capillary plexus. The tension within the ischemic area is much lower than it is in the normal myocardium. So therefore, the blood's going to cross right into the ischemic area. It's like it's tailor-made. The retroperfusion has been tried previously by Beck back in the 1940s, when he tried to create a shunt between the aorta and the coronary sinus. This would propel arterial blood into the coronary veins. Unfortunately, he had some trouble with this because the cases usually ended up with cardiac decompensation. Now, the reason for the complications was that Beck didn't allow for venous drainage of the coronary veins. By doing this, he caused a congestion of the heart muscle that led to their death.
The major advances or differences between diastolic retroperfusion and the original Beck procedure is that now the retroperfusion technique is synchronized to the heartbeat. Consequently, the heart sees the arterial blood only in diastole.
Dr. Corday describes the technique that he has perfected.
We pass the retroperfusion catheter into the jugular vein, and down into the coronary sinus, across the great cardiac vein, to this particular area supplied by the occluded left anterior descending coronary artery. Thus we can prevent, by pumping the arterial blood down from the jugular down into this vein, we can prevent infarction from occurring in the distribution of the LAD.
Coronary sinus retroperfusion is demonstrated in this simulation.
The lower tracing is a simulated ECG. In the upper tracing, one sees the R wave from the ECG, and then after an interval, which is 45% of the R to R cycle, the pump stroke representing blood flow in diastole. Blood is then delivered through a triple lumen balloon catheter into, in this case, a model of a coronary sinus. You can see that with each heartbeat, the blood is propelled through the catheter. Balloon inflates in diastole to provide unidirectional flow and prevent blood loss into the right atrium. In systole, the pump stroke is interrupted and the balloon deflated to allow for normal coronary venous drainage. Our major experience in the animal laboratory has been in an acute left anterior descending coronary artery model where the treated animals received 5.5 hours of retroperfusion therapy. And when we compared infarct size in the treated animals to the control animals, we found that there was a 60% reduction. To determine the ability of retroperfusion to deliver blood to the myocardium, we employed positron emission tomography with rubidium-82 as the flow tracer. This tomographic image, was obtained in control and demonstrates homogeneous blood supply to the myocardium. The middle image was obtained after occlusion of the left anterior descending coronary artery and demonstrates absence of perfusion to the anterior myocardium. Retroperfusion therapy was then begun and the rubidium injected into the retroperfusion circuit. And you can see that the anterior myocardium is now receiving rubidium, thus receiving blood to the area where the blood was not supplied because of the occlusion of the coronary artery.
The arterial blood keeps the heart muscle alive. Contractility returns in seconds. Also, the metabolism returns, the glucose metabolism returns almost immediately. Thus, we can prevent infarction. And if infarction does occur, it's very small compared to the control.
Elliot, welcome in the studio as well. Thank you for that very interesting videotape. Now, can you tell us about damage and complications that this procedure might cause? You've had a lot of experience in the experimental animal.
We're not seeing any damage now, Jeremy. We monitor the pressure of the coronary vein to make sure that it doesn't rise above 50 millimeters of mercury. Now, with such monitoring, we can avoid this completely.
And you think that this possibly applies in man as well?
Yes, we do. We've had very good luck treating 70 people with this technique. No damage at all.
Right. Now, you are actually using a relatively small stroke volume. As I recall, it's between 2 and 4 ml.
Yes.
How do you explain that this, in fact, attains a perfusion of the ischemic zone?
If we want to save the heart muscle, we find that we have to just about double that. And we've developed some new pumps that will deliver about 3.5 ml. In other words, just double what we've used before, and it looks very good.
And can that be done without exceeding your pressure in that coronary sinus?
We always watch the pressure, and we find that it doesn't climb too high.
Very good. Now, Elliot, I noticed that in your experimental model, that was an anterior descending coronary artery. Could you tell me about your experience with other vessels, such as the right or the circumflex?
Well, you're quite right. That is the LAD, and that appears to be our maximal benefit. We will see it in the LAD. However, the right coronary is very important too, and so is the left circumflex. We now find with our new pump that we can reach both those areas as well. Particularly, we can get into the circumflex when the left circumflex coronary artery is occluded.
Now, I noticed in your model that you pointed almost to the anterior coronary vein. Are you able to get the delivery catheter that far up, or do you pump in the coronary sinus?
We go into the great cardiac vein, up into the anterior cardiac vein, yes. We find we can go all around the heart, from the anterior surface all the way across to the posterior surface with our new pumps.
And Elliot, for how long do you think that you could sustain a heart? I know your experimental data is 3 hours or 5 hours, as Dr. Drury indicated. Have you taken this to any longer time periods?
Yes. We had another patient more recently on 5 hours, and it did very well. He was a very high-risk patient. We knew they were going to get in trouble. Also, Gore has treated a case for 60 hours while waiting for the surgical team to come back and do a coronary bypass on this patient. And apparently, it preserved the heart for all that period of time.
Thank you very much, Elliot. After the break, we'll come back and visit with Dr. Kanu Chatterjee at UC San Francisco, who will discuss clinical applications. Don't go away.